Welcome to Facing Dementia, a doctor's perspective and a caregiver's journey. Please keep your microphones on mute. If you have questions at the end, use the raise hand function. I'm pleased to introduce Luana Panasco, the president of NACRA, to open the program.
Thank you, Chuck. I'd like to welcome everyone to the NACRA Zoom webinar and thank our participants, Dr. Matthew Barrett and Mary Lou Falcone. I wish also to recognize Mr. Paul Wynn of U.S. News and World Reports and Dr. Charles Webb, our NACRA director, for their efforts in organizing this webinar. At this point, I will turn things back over to Chuck to carry on the meeting.
Let's see if I can. I'm pleased to introduce Dr. Matthew Barrett, professor of neurology at Virginia Commonwealth University. Dr. Barrett graduated from Notre Dame, earned an MD at the University of Virginia in Charlottesville, where he also did a residency in neurology. He earned a master's degree in research methods from Albert Einstein College of Medicine in the Bronx. And he did a fellowship at Mount Sinai Beth Israel in New York City in neurology. His bibliography on the National Library of Medicine website has 77 different citations. He specializes in movement and cognitive disorders. VCU is recognized as a center of excellence in movement and cognitive problems by the Parkinson's Foundation. He's an excellent speaker to specialists in brain diseases to present a doctor's perspective on dementia. Welcome, Dr. Barrett.
Very good. Thank you very much. I'm happy to speak to you all today about dementia and how a neurologist approaches it, or other providers might. What I'm hoping that you get out of the talk today is answers to these questions. What's dementia? How is it diagnosed? What are the common different causes of dementia? How we treat it, how it can be prevented, and what are available resources for family members. And throughout this, especially around diagnosis and treatment, I'm going to share with you some recent developments just over the last couple of years. So first, a good place to start is to define dementia, at least what it means to a physician or a neurologist, and that is a decline in memory or thinking that is severe enough to interfere with activities of daily living and in some way results in a loss of independence. And this could be some activities such as managing finances, pulling together tax paperwork, managing medications and refills, and driving. So some of the even more complex activities of daily living, if impacted by memory and cognition, would meet the criteria for dementia. There's a lot of different causes, and this is what we'll spend most of the time talking about today. Alzheimer's disease is the most common, so we'll spend some time on that. I think we're going to also, at the end of my presentation and then later on, hear more about Lewy body dementia today, which is the second most common cause of neurodegenerative dementia. Vascular dementia is also fairly common, and then I'll mention frontotemporal dementia as well. All of these together are sometimes referred to as Alzheimer's disease and related dementias because they all share some characteristics. Again, Alzheimer's disease is the most common, so I think that's why it takes the lead, but all of these conditions can teach us about the others, and certainly in regards to care and even potentially in the causes and treatments. And there are other non-neurodegenerative causes of dementia that I think we want to certainly exclude early on, and even some other causes. We think of, though, largely that dementia is an irreversible condition. If someone has something that's reversible, it may look like dementia, or could be something like delirium, which is very temporary and related to other medical issues. You may hear the terms mild, moderate, and severe dementia. This can indicate the level of impairment. Mild, just those very complex daily activities I mentioned early on. If someone is needing increasing help with their activities of daily living, then they may meet the criteria for moderate or severe. And I think it's important to point out what dementia isn't. So it is normal. There's normal aging, and normal aging could be slight forgetfulness, slightly slower thinking, but still independent, and occasionally forgetting names or misplacing items, but remembering them later. I think that's the important part. Could be all in line with normal aging. There's subjective cognitive impairment, where individuals may notice memory or thinking problems, but when we do formal testing, it shows normal function. This is something that probably needs to be followed over time. And then there's this stage, mild cognitive impairment, where individuals have some cognitive impairment that's measurable. It's been a change from their prior, but it's not yet interfering with their activities of daily living. Someone that has mild cognitive impairment, often abbreviated as MCI, may go on to develop dementia, but not everyone does. But it is certainly something, an area where we want to capture people early, potentially, especially if there's some treatments that might be applicable to them. When we talk about dementia and even cognitive impairment, I think everyone first thinks about memory. It's important to recognize, though, that other areas of cognition may be affected. Executive function involves planning, multitasking, and that can be preferentially affected in some conditions. Attention, visual-spatial function, and language are also other areas of cognition. Language may be the first and prominent area affected for some individuals. This is called primary progressive aphasia. I'll mention that a little bit later on, what diseases may present that way. But certainly when it comes to Alzheimer's disease, we think about memory impairment. The reason it's important to talk about this topic is that it's common and can affect us all, potentially personally or certainly in people that we know. So according to the Alzheimer's Association, over 7 million Americans are living with Alzheimer's, and this number is expected to increase over the next 25 years to 13 million. Over the age of 65, about 1 in 9 people are affected by Alzheimer's. And the risk for people at age 45 is 1 in 5 for women and 1 in 10 for men. And that's for Alzheimer's specifically, which does seem to have a predominance amongst women. And then, as I pointed out earlier, nearly 12 million Americans are caregivers. I think many more of us know people that have had dementia or have had extended family members that we maybe didn't provide care for that have suffered from these diseases. So now I'll talk about how a neurologist would approach this. So if I see somebody in my clinic, the first thing I want to do is hear about what types of cognitive changes they've been experiencing and exactly how that might be interfering with their daily life, if at all. And then it's always very nice to hear from family members about what they've noticed, because sometimes the individual having cognitive changes isn't as aware of it. It's not unreasonable or uncommon to do some sort of screening cognitive test, and they're called an MMSE or mini mental state exam or a MoCA, Montreal Cognitive Assessment. These are 10 to 15-minute tests that can be performed in the office. I think we never want to base a diagnosis on the results of those tests. So sometimes there's more extended testing in the clinic, and there can be neuropsychology or neuropsychological testing with a specialist who does this type of work. That can range from anywhere from 2.5 to 3.5 hours of testing to really understand what someone's cognitive changes are. At this stage, we like to do screening labs, or at least make sure they've been done so we don't miss something like B12 deficiency or a thyroid problem that's gone undiagnosed. There are some other labs we might check based on the person's history. And then I think it's very common to get some sort of brain imaging to make sure we don't miss some condition that may be mimicking or looking like dementia. That's also another neurological condition. It's also good to look for evidence of vascular disease that may have not presented in the past. And usually when we pull together all of this early data, we can come together with some idea of a preliminary diagnosis. And then from there, we can either confirm that diagnosis or at least explore it further. When it comes to Alzheimer's disease, what makes us think that someone might be suffering from Alzheimer's is that they do have prominent early memory loss. And this memory loss is a difficulty in coding new information. So that when a person is asked this information later on that they've been told to learn, they're unable to recall it. And no amount of cueing or oftentimes cueing doesn't help, that they've never been able to store the information and so they can't retrieve it later. And this can lead to things like repeating stories and questions, not remembering what happened earlier in the day because they've never formed those memories to begin with. There's a part of the brain that is involved in this called the hippocampus, or the medial temporal lobes, and that's what the orange arrows are pointing to at the bottom. Other symptoms might be getting lost while driving, and again, I think for Alzheimer's especially, lack of awareness of these issues, especially around memory, is a common feature of the condition. So it's often not the individual suffering from this that is coming to the office alone, although that does happen, but it's often family members that are bringing them. And we can get some early indication just from a brain MRI that these memory structures that the orange arrows are pointing to may be affected. On the left is a normal hippocampus, these memory structures, and on the right is a loss of volume of these structures. So you see the black fluid-filled space is enlarged, and the brain structure is actually smaller, and that gives us some indication this area is affected and may indicate Alzheimer's disease. Over the last really 20 years, we've had tests we could use to confirm if someone had Alzheimer's disease, and we've had PET scans and we've had spinal fluid tests. We weren't doing these too often because it didn't clearly influence treatment, but I'm going to tell you why that's changed in the last couple of years. And what's really been added to this list is a blood test, which these are very close to widespread acceptance as being highly accurate. And it's again as simple as a blood test to diagnose someone with the changes in the brain that might be Alzheimer's disease. I think the important thing is to always take these tests in the context of what an individual is presenting with, and it's usually going to be some symptoms of Alzheimer's disease. Vascular dementia can present a little differently. Individuals usually don't have that same type of memory problems. They have more difficulty with executive function, that multitasking, task involving sequences and planning. Their thought processes might be slower. They might have difficulty with attention and focus. It's not uncommon that with vascular dementia, they have vascular risk factors, so high blood pressure, cholesterol, diabetes, smoking, maybe a history of stroke. And an MRI can give us evidence that there's been some vascular injury to the brain. We can see old strokes, but we can also see when there's been damage to the small blood vessels in the brain, which wouldn't show up as a stroke. Patient wouldn't have symptoms related to that. But as this white matter disease or small vessel disease increases, we can both see that in an MRI, and it can eventually cause cognitive issues, sometimes changes in motor abilities and walking. So on the left is a fairly normal brain. There's not that white signal that you see increasing to far right, and that's again evidence primarily of vascular damage related to usually vascular risk factors. I don't talk too much about frontotemporal dementia today, but we do encounter it. It's certainly less common than the others I'll be talking about. The history is interesting. It's very different than what we see in Alzheimer's or vascular dementia or Lewy body dementia. Individuals can present with two different types. One is a behavioral variant where because the frontal part of the brain is affected, which involves their personality and behavior, they can have many different changes in their personality: apathy, loss of empathy for others, repetitive behaviors, changes in diet, with usually focusing on certain dietary items. Or they can present with a primary progressive language problem, which is called aphasia, and they can lose the ability to have fluent speech, or they can lose the ability to know word meaning. And the way that we diagnose this test, we don't have any biomarkers specifically where we measure protein levels in any way, but an MRI often can give us some indication that someone has the frontal or temporal parts of their brain affected. So in that panel A, that's the temporal lobe on the left is smaller or atrophic is what we say, and that's evidence of this frontotemporal dementia. And then at panel B, that's the frontal lobe. And then a PET scan, a glucose PET scan, can show metabolism in the brain, and that area in that frontal that is not as lit up is an area where the glucose is not being used as the brain, so the brain's not functioning as well. So that's a frontal part of the brain, and you would only see just that frontal part affected in frontotemporal dementia and not other dementia syndromes. So how do we treat dementia? I'll start first focus on the medicines I think people may have encountered. Aricept is the most common. That's the brand name in parentheses, and donepezil, rivastigmine, galantamine. These are all different drugs that have similar effects. So they're in the same family. And all of these drugs work by increasing a brain chemical called acetylcholine. Most of these drugs have been studied, or they've been studied for the most part in Alzheimer's disease, and many studies, and across these studies do show some benefit. But as I state here on the bottom, the cons are that the benefit is modest and rarely noticeable to patients, and they can have some significant side effects. But at least across studies, there is some benefit, and we do often try these. There is some evidence to use these in vascular dementia as well, and I'll talk about there's evidence to use them in Lewy body dementia. Memantine, Namenda, I don't have the brand name on here, is a different drug. It works in a different way. It's indicated for moderate to severe Alzheimer's disease. It's not been clearly shown to be helpful in other areas. I really see it as an add-on therapy, although it could be used alone to those first group of drugs. Similar to the cholinesterase inhibitors, those ones that increase acetylcholine, or that chemical in the brain, these have a pretty small effect. But they've been at least shown across multiple large groups of people to be helpful. And they don't have a lot of side effects, which is one advantage. And there's a lot of other medicines we might bring to bear in someone that has dementia. There's antidepressants. We want to treat any psychiatric symptoms that are bothersome and borrow from psychiatry to do that. We want to use some of these with caution, like the antipsychotic medications, but certainly when there's bothersome hallucinations and delusions, we want to treat those if those are causing agitation or distress to the individual. And I think it's always important to talk about behavioral strategies. I'm very cognizant of the fact I'm talking about the medications before all of these other non-medication options, but I recognize the non-medication options can be as important, if not more so sometimes. So strategies that help to redirect, distract, reassure, rather than potentially always our intuition of correcting someone, especially around memory lapses, may be more helpful and less agitating. Physical activity can be helpful, I think, especially around how it can help regulate sleep and how important that is. Routine and schedule can help someone reduce opportunities for agitation. Social engagement, as long as it's not agitating, certainly can be helpful. It's important for people to maintain that, and then to get as good a rest and sleep as necessary. I'm going to simplify what I have here, but I think it's important if we talk about the more recent developments in Alzheimer's treatment to give you a sense of why these therapies came about. So in Alzheimer's disease, there's this idea that amyloid, which are the plaques that can form in the brain, are really a primary source of what develops in Alzheimer's disease. And the amyloid plaques, maybe reading down the right side might be the easiest way to get through the slide, can result in tau, another protein, accumulating into tangles. And then together, and especially the tau tangles, lead to loss of volume of the brain and neurodegeneration. And ultimately the symptoms that we associate with Alzheimer's disease. So because of that, individuals have focused on the amyloid and how do we clear out the amyloid, get rid of it, keep it from forming, lots of different potential strategies to do that. What's been really helpful in developing treatments that might do that is the ability we could measure amyloid in the body. And this is something where Lewy body dementia has lagged behind until fairly recently. Again, as I said earlier, there's been about 20 years of our ability to measure amyloid in the brain using a PET scan, using spinal fluid markers, and now to use blood markers. And if you can measure this in the body, then you can test whether a therapy is actually able to clear it and change potentially the amount of amyloid and plaques that someone has in their brain. One strategy people have looked at to do this is through using antibodies. So all these little orange cylinders that are either alone or clumping together are indicating the amyloid plaques, and the little Y-shaped figures there are the antibodies. And those antibodies can bind. There's been developed a lot of antibodies that can bind to amyloid plaques and then co-opt the immune system to clear out the amyloid. I'm going to just point your attention to two of these. donanemab, the D drug, and lecanemab. Mab at the end of these stands for monoclonal antibody. So it's an antibody that is just a single type that can be given as a drug. And this has been used in other areas of medicine. This was, fairly new to be used in a neurodegenerative disease. And what these drugs were able to do is clear amyloid out of the brain. So on the left is a PET scan showing amyloid in red, and along that left part of the left panel, that's all pictures of individuals with amyloid in the brain. And as you see on the just right side of that panel, the placebo does not change that after a year. You see the same amount of amyloid, but as you give increasing doses of one of these antibodies, you can remove the amyloid from the brain. This has been something we've known can happen for about 15 years. We can clear the amyloid out of the brain with these drugs. What hadn't been shown until more recently is that this actually slowed the disease down. So on the right side are the results from 2 clinical trials. Time is across the bottom. These were both 18-month trials, and worsening is on the left, the y-axis. So over time, but all groups are worsening. They're all sloping down. But the individuals that got placebo sloped down faster than individuals that got either of the drugs. Donanemab is on the bottom, lecanemab's on the top. So this was evidence that these drugs, not only do they clear amyloid out of the brain, but they actually seem to be slowing the progression of the disease. The controversy that you may have heard about these drugs is, well, in part, aducanumab, the one not on those slides, was the first drug where this really kind of hit the press. And aducanumab had mixed benefits, so they were not able to consistently show benefit across multiple studies, whereas the 2 approved drugs that are now being used showed benefit consistently. However, the benefit is small. It's significant but small, is the way I like to talk about it. And we could think of it just as a first step. It's important that we've been able to show we can clear amyloid, that we can slow the progression of the disease. These aren't perfect therapies and certainly can be improved upon, but they are a step in the right direction and the result of a lot of years of research and trying to understand what causes these conditions. Another thing to consider with these therapies is that they can cause brain swelling and brain bleeding. There are some individuals that are probably more at risk, that are more at risk of this based on their genetics. And there are ways that we can mitigate or manage the swelling and the bleeding, in part by making sure someone's not on any other blood thinners or be prone to have that bleeding get worse. We also monitor people with MRIs if they get the treatment, so that if they have any small amount of swelling or bleeding, that we capture it before they have any symptoms and then potentially suspend therapy. That being said, there's a burden to treatment. Every 2 weeks for one of these drugs, the lecanemab, and then every 4 weeks for the other, individuals have to come in and get an infusion at an infusion center. And so it takes a condition where we didn't treat it in this way into a completely different arena. It's also important to recognize the best time to use therapies like this is very early in the disease. And so sometimes people present at times where their disease has progressed more than is probably going to be helped by these types of therapies. Now I'll just say a few words about dementia prevention. I think this is relevant to people that might be having cognitive impairment, but relevant to all of us who aren't. This is based on a group that got together for the Lancet, which is a big UK journal, to determine what are all the factors which are modifiable in terms of our risk for dementia. And they found that nearly half of the risk of someone developing dementia could be controlled in part by lifestyle factors or other factors. And what's been added more recently, what I think always stands out to me, is hearing loss. Untreated hearing loss is a risk factor for dementia. Visual loss was added in this most recent update, and then high cholesterol was added in the update. So you'll see some of the things here that lead to vascular dementia, excessive alcohol, social isolation, air pollution is an interesting one. It's so all of these things I think we've all heard about in some ways. This actually tries to quantify in what way it can contribute to dementia risk. So important thing to talk about, I think, is where to turn for help. I think there are more than just neurologists that can evaluate this. Primary care doctors certainly have a lot of experience evaluating individuals with cognitive issues, geriatricians especially, a specialized area of internal medicine, geriatric psychiatrists, and I work closely with a neuropsychologist, and sometimes they're the first provider people see when they're having cognitive changes. There can be a role for speech therapy, especially around cognitive rehab, and some speech therapists are trained in doing that. There are centers where people specialize in the treatment of Alzheimer's disease and related dementias. This doesn't have to be in an academic center. Some private centers are offering this type of care. A social worker can be incredibly useful around changes in a person's status related to where they're living and their needs, and potentially bringing resources into the home. Alzheimer's Association is probably the foremost patient care organization. That certainly offers a lot of resources through their website. There are patient and caregiver support groups through multiple avenues that I think can all be helpful. So now I'm going to shift and talk about Lewy body dementia. I mentioned earlier it's the second most common cause of neurodegenerative dementia. It affects about 1 million individuals in the U.S. And just to try to clarify this, hopefully not confuse things, Lewy body dementia is really an umbrella term for dementia with Lewy bodies and Parkinson's disease dementia. Individuals with those two conditions look very similar, although they've had a different trajectory or different course. Individuals with Parkinson's disease dementia have had Parkinson's disease first, sometimes for as long as 15 to 20 years, and definitely more than 1 year to meet this 1 year rule, and then have later developed cognitive issues. Whereas someone with dementia with Lewy bodies has dementia either preceding any Parkinson's symptoms or in the same or the first year that they have either. We think that the same process is underlying both of these conditions, and so I think it's very reasonable to think about them as together as Lewy body dementia, and the treatments are largely the same and largely will be the same because of that same underlying cause. Compared to Alzheimer's, Lewy body dementia is associated with accelerated cognitive decline, greater caregiver burden, and higher healthcare costs. And this is likely related to the fact that there's not only the cognitive aspects of Lewy body dementia, but also neuropsychiatric symptoms like hallucinations and delusions, and then the motor impairment, which can lead to falls, and sometimes difficulty regulating blood pressure, which can also contribute to that. So there's just a lot more burden on patient, but also on their family members because of these other issues. There's an increased risk of delirium and higher rates of hospitalization and nursing home placement, probably again all related to those other symptoms associated with it. So what are Lewy bodies? In the name, they are something only seen under a microscope, abnormal accumulations of this protein called alpha-synuclein. And they clump together in these spherical shapes that are inside of neurons. And then those neurons affected are in the cortex of the brain, limbic structures, and in the areas where the Lewy bodies are in neurons are the areas affected by the disease. The diagnosis is based on the presence of dementia, so some cognitive impairment, and the areas are a little bit different than we see with Alzheimer's. So the areas affected are executive function, visual spatial function, so visual processing, working memory, which is inability to maintain thoughts in someone's or maintain the track of their thoughts over time, rather than their inability to retrieve information. And then also can be attentional issues. Fluctuations in attention and cognition are an aspect of Lewy body dementia and sometimes present along with excessive daytime sleepiness. Other symptoms that can occur I'm going to talk about in the subsequent slides. So another new thing over the last couple years is that we have a couple ways of measuring abnormal alpha-synuclein as would be seen in Lewy body dementia. Without looking at the brain. And two ways to do this are with a skin biopsy, and another is through a spinal tap, which measures the alpha-synuclein protein and whether it's abnormally folded. So both of these are getting us closer to where Alzheimer's disease has been for, again, many years. Our ability to actually measure that someone has the protein changes in the brain that accompany the disease, and so we can potentially develop treatments targeting that. As far as treatment, it's similar to what I brought up earlier with Alzheimer's disease, but I think the important thing for Lewy body dementia is that these drugs may work better, especially around sometimes the hallucinations. And so important to try them early, and if someone doesn't tolerate one, to try one of the other ones, because usually there is some benefit. They don't entirely change the course of the disease, but they can help some of the symptoms and help people almost stabilize for a couple of years. There are side effects, and another thing just to point out is there are some medicines that you would want to particularly avoid with Lewy body dementia. These are called anticholinergic medicines that actually block acetylcholine in the brain. I think it just takes a physician aware of that to kind of review a medication list to know if someone's on a drug that actually might be worsening their cognition and maybe even their hallucinations. So I've mentioned the hallucinations. Visual hallucinations are common part of this disease, actually built into the criteria. They can be of people and animals. They can be much more minor than that, but it's the more well-formed ones that we think are characteristic of the disease. And sometimes individuals have delusions, which can be pretty distressing, especially if they're paranoid or have concerns about other people trying to harm them. That can be a really difficult symptom to manage. The drugs that we use for dementia can be helpful, so I always like to make sure people are taking those. And sometimes we have to revert to using some antipsychotics. There are three that don't seem to worsen people's other symptoms of Parkinson's related to this condition. But there are definitely some antipsychotics that are important to avoid. And sometimes, unfortunately, people end up in an ER and are given drugs that they should not receive if the Lewy body dementia has not been recognized. REM sleep behavior disorder is a core feature of this disease. It can happen prior to symptoms occurring. And what it is that during REM sleep or rapid eye movement sleep or dream sleep, individuals, rather than being paralyzed, act out their dreams. And sometimes these dreams can be quite violent. They can be kicking and punching and even fall out of bed. So sometimes the treatment is just moving sharp corners away from them, getting the bed as low as possible. Sometimes a sleep study would be reasonable to consider to make sure someone doesn't have some other sleep disorder. What we now know is that having that type of dream enactment is highly predictive of someone having a condition like Lewy body dementia or perhaps Parkinson's disease. And we treat that by, melatonin and benzos. There's a whole symptom area called autonomic symptoms. The autonomic nervous system controls automatic functions in the body, so blood pressure control, heart rate control, urinary control, and the GI tract. And so symptoms related to that can be drops in blood pressure with standing, called orthostatic hypotension, urinary urgency and frequency, and constipation. And there's many different ways to try to manage these symptoms depending on what's bothering someone. And then lastly, Parkinsonism. So I'm using that term because this is to refer to the symptoms of Parkinson's rather than Parkinson's disease, because you're seeing Parkinson's symptoms occurring in someone with a dementia syndrome. And these primary symptoms are slowed movement, stiffness when trying to move someone's limbs, that's called rigidity, resting tremor, and imbalance, so tendency to lose balance. The treatment for this is levodopa, the same as we would use with Parkinson's disease. This is probably the best and sole drug to use. There's a lot of other drugs we might use to treat the motor symptoms of Parkinson's. Some of them could actually worsen some of the cognitive symptoms, so we want to be careful about that. We also have to be cognizant of this idea that treating motor symptoms with levodopa, could worsen the hallucinations and the blood pressure control issues. So sometimes there's a balance between treating one of these symptoms and trying not to worsen one of the others. And there's a role here for physical therapy, occupational therapy, speech therapy. As part of Parkinsonism, individuals can have a low voice, can't project, and so speech therapy may be helpful for that. So many of the things I mentioned earlier as places to turn for help are relevant to Lewy body dementia. Just to highlight a few, physical therapy and occupational therapy may be more relevant here because of the motor impairment. There's also a role, I think, for more specialist care potentially. Psychiatrists can be helpful in all dementia, but certainly in Lewy body dementia, I didn't even mention that there's a greater likelihood someone is suffering from depression, anxiety, or apathy. Cardiology could be helpful for managing some of these blood pressure and heart rate issues. An autonomic specialist can do the same, and then a sleep specialist because of these sleep disorders. I didn't mention insomnia and hypersomnia, but both of those can also occur with Lewy body dementia. There's the Lewy Body Dementia Association has a lot of resources online. There's other groups that have resources as well. There can be respite care, community resources, and I think support groups for some people can be quite helpful. And clearly, we have areas for opportunity, and some of these are related to the fact that I think diagnosis can be delayed with Lewy body dementia, and individuals may receive the wrong treatment if that's not done in a timely way. So we can always improve upon educating people about these conditions, but also finding better tools to earlier diagnosis. There's still, I think, a role to improve the treatments we have for some of the symptoms. And then more than that, we have to figure out a way to slow these diseases down and halt them at best. So we think of those as disease modifying treatments, that we're actually modifying the underlying disease. And treatments that might modify the underlying disease are those that target this alpha-synuclein, this abnormal protein. There was a recent trial, the SHIMMER trial, we participated in to study a drug that would actually clear abnormal alpha-synuclein. Neuroinflammation or inflammation in the brain is a part of these neurodegenerative diseases, and there are now treatments being developed that target these. And there's probably a role for treatments that target Alzheimer's pathology. So we know that individuals with Lewy body dementia, a large proportion of them have some Alzheimer's changes in the brain, and these therapies that are being developed for Alzheimer's certainly could be potentially relevant to patients with Lewy body dementia. So we have plenty to learn about that. I think I'm finishing a minute early, but it gives another minute to our other speaker and potentially questions.
Okay. Thank you very much, Dr. Barrett. It's my pleasure to introduce Mary Lou Falcone. She sang opera for 8 years and was on the faculty of Juilliard for 22 years, teaching in other universities in the United States and Europe. In 1974, she started a public relations company, and she's helped guide and propel artists' careers. Van Cliburn, Renee Fleming, James Taylor, Isaac Stern, by coordinating with Carnegie Hall, the Vienna Philharmonic, and multiple American orchestras. It's been quite a career. She's very well known in Manhattan. In 2015, her partner, Nikki Zahn, developed symptoms of dementia. She became his caregiver. She wrote of her experience in a book, I Didn't See This Coming. Now, let me mention also, when she was 10 years old, her father suffered a severe stroke and became aphasic. To hold the family together, her mother took 3 jobs, and Mary Lou was a caregiver for her father and her 2 younger siblings over those years. And then she was a caregiver for her husband. This past fall, she produced an hour-long video on caregiving, on how groups can be helpful. She serves on the board of the Lewy Body Dementia Resource Center in New York. She's an excellent person to present the caregiver's journey. We welcome Mary Lou Falcone.
Thank you, Chuck. I really appreciate being here today. So it's a caregiver's journey. That's what I'm going to share with you is my personal journey. And I've done it through my book, which is shamelessly behind me, the I Didn't See It Coming, Scenes of Love, Loss, and Lewy Body Dementia. But also I'd like to share today a brief history of my caregiving. So I call it a love story. And that's what is the bottom of everything, is the love that goes into all of this. It's a story of overarching themes of Lewy body dementia, of caregiving, of hope, and resilience. 2 very important words, hope and resilience. I like to think of my adult life in three acts. Chuck alluded to some of it. My first act was as a singer and a teacher. My second act was as, and still is, for the last 50 plus years, as a public relations strategist in the area of classical music. And my third act, and I think in some ways my most important act, is as an advocate and spokesperson for Lewy body dementia, hoping to obliterate two phrases, one being Lewy what, and the other being, how do you spell that? And for those of you who may not know and didn't catch it on the screen, it's Lewy. Very important because you can't find it if you can't spell it. So let's go back to the beginning of my caregiving journey. The year is 1955. I'm 10 years old. My father has a massive stroke. He lives, which is a miracle because he was misdiagnosed. When he comes home, he's unable to speak. He's unable to walk. He learns to walk. He never speaks again for the rest of his life. He was 37 years old. He died when he was 64. So without the ability to communicate via speech all of those years, I became the caregiver for my younger brother and sister, and also for my dad, as my mother went out to keep the family together, holding down 3 jobs. What saved me during this period was music. You know, emotionally, a kid of 10 doesn't know what to do with the emotions. And while most kids could go to their parents, and of course I could go to my mom, but I wouldn't because she was already burdened with so much and she didn't need another area of being burdened. And so I found music, and I found that when I sang, the adults in the room wept. And that set me on a path to go to the Curtis Institute in Philadelphia, which was an all scholarship school, and ultimately to singing for 8 years. So there I am as a singer between the ages of 20 and 28. 28, I started a business, public relations business, because my real calling is helping the careers of others and helping others. That's become evident over my almost 80 years on this planet. And so I basically started this public relations business in 1973. Now, 73 became an extraordinary year because I also met the love of my life, Nicholas T. Zan, known to all as Nicky Zan. Let me stop here and just give a thumbnail sketch of Nicky. While I was doing what I was doing in the 1950s, Nicky was a rocker. He was a teenage idol on the same stages as Johnny Cash, Patsy Cline, and Jerry Lee Lewis. So he was a for real rocker. At age 21, so that was 7 years later, he decided enough of this rock and roll. I'm going to become an artist. And he always painted, he always drew. And he put together a curriculum that got him where he needed to go. By the time he was 30, which is the year that I met him, and I was 28, Nicky had become a very celebrated artist. His work was already in the Victoria and Albert Museum in their permanent pop art collection, where it still is. So Nicky was also probably the kindest, most generous, funniest person I had ever met. We met across a crowded room in 1973. You could hear Rachmaninoff in the background, at least in my head. And there was just this incredible pull toward Nicky Zan, and he toward me. And so we met, and up came this lovely lady who happened to be his wife. All romantic inclinations were stopped in that moment, and the 3 of us became incredibly good friends. In 1983, 10 years later, Nicky and his wife, Mary Jo, amicably divorced. They wanted to go in different directions, and Nicky and I became a couple. So we were friends for 47 years. We were together as a couple for 37 years, and we were married for 3.5 years, and I'll get to that a little later. And so we had a storied life. We traveled, we were building our businesses, our separate businesses. We were very supportive of each other. And then 2016 came. In 2016, I began to see some really strange behavior. It was erratic behavior, forgetting, occasional anger, paranoia, fatigue, and taking 20 minutes to write one check. Now, we can all find all kinds of reasons why these things are happening and make excuses, and I certainly was no exception to that. I made the excuses. By the end of that calendar year, by holiday time of 2016, we were in Vienna, and Nikki, something happened that was so dramatic, and that is that he got lost, meaning he was supposed to meet friends and I for dinner at 8 o'clock this particular evening. No Nikki. 8:45 came, no Nikki. I went out, excused myself, and went out to see if I could find Nikki in Vienna. Now, that's like finding a needle in a haystack. I mean, good luck, right? An hour into my quest, who's coming toward me? And this is divine intervention, I know, Nikki. And as I looked into his eyes, what I saw was fear. As he said to me, you're the culprit. You didn't write down that address. It's your fault. And I just went silent and quiet and said, you know what? You're totally right. It is 100% my fault. Can you please find it in your heart to forgive me? That was the beginning of seeing something that was really different. We went on then to Paris, where one night he woke up drenched in sweat and shivering and felt kind of heavy in his chest. Next morning, he was fine, thought nothing of it. Back to the United States. Now we're into 2017. He goes to his doctor, which he did every 6 months for a general checkup, very conscious of his health and being in good shape. And he says to our doctor, and what happened to that calcium score test you had me take 6 months ago? And our doctor says, oh, gee, Nick, let me look. Looks, turns sheet white and says, we need to get you to a stress test immediately. Evidently, the calcium score test numbers were off the charts, dangerously so. Nobody had flagged it. Went to the stress test. They said he'd had a heart attack. Well, that I could pinpoint to that evening that I told you about in Paris, where the sweats and everything that went with it. From there, we were sent to a cardiologist. The cardiologist said, you know, this is probably normal. People need medications or they need stents. That's the extent of it. I had a really bad feeling. I basically said to Nikki at that point, Nikki, you've been asking me for 34 years to marry you. And I've said no every single time because we've had a great relationship and why spoil it with a piece of paper? But now I'm asking you, will you marry me? And typical Nikki fashion, he looked at me and said, you know, Mary Lou, it's only been 34 years. What's your hurry? Well, he did comply, and we did get married on the 13th of February of 2017. The 14th of February, we were in Mount Sinai for an angiogram. And on the 15th of February, Nikki had triple bypass surgery. That was the beginning of the end. For the next, I would say, 13, 14, 15 months, no improvement. Hallucinations continued. They started with the surgery, they continued beyond that. And so did fatigue, weight loss. He couldn't afford to lose a pound, and he was losing weight, and it was really serious. Changed doctors. Our new doctor, now we're into the fall of 2018, and our new doctor, I said, no, I think we need a baseline MRI. And he said, let me watch for another month. During that month, we went to Stockholm, Sweden, where Nikki couldn't figure out how to get through the metal detectors at the airport. We got to the hotel. He could not figure out how to get from the front desk to the hotel room. Furthermore, he would sleep all day. And the activities that I was running, I was doing a large event there. The activities took place at night where Nikki would get dressed in his black tie, and having slept all day, he'd be on. So the fluctuations were already starting. And there he was, being the toast of the party and the, just completely 100% Nikki Zan, and nobody knew that anything was wrong. So in medical terms, that's called show timing. And he was show timing big time and could do it. And he was a person of the theater, so he knew how to work the room in that way. When we got back to New York, I said to our new doctor, MRI now, please. By January of 2019, MRI took place. It showed, and I hate this phrase, age-appropriate deterioration. To me, that's nonsense, for we don't have a clue of what's going on. I said, okay, what next? And our doctor didn't miss a beat. He was phenomenal. He said, I'm sending you to a neurologist, the best neurologist I know. But he didn't say the best neurologist for what. He just said the best neurologist. And the neurologist was out of our normal network, which I thought was interesting. We went to the neurologist. They watched Nicky walk, and they gave him a general cognitive test that we all take from time to time. And the neurologist said, this is Lewy body dementia with Parkinsonian aspects. We knew what that was. He said, further, I'm going to do a DAT scan, which is like an MRI with dye, and we're going to do a REM sleep test. Within 2 weeks, those tests were done. We went back. The neurologist said, this is Lewy body dementia with Parkinsonian aspects. When we got to the waiting room, Nicky took me in his arms and he said 3 things. The first was, I've always wanted to meet your father, and now I'll have my chance, which was his way of letting me know that he knew he was dying. And my father died in 1981. And second thing he said was, we have had a great run. We cannot be sad. Those are words that I live by every single day. And the third thing he said was a request. And that is, I know that the sledding is going to get very rough. Please help me to keep my dignity. And so our journey started. As brilliant as the doctor was, who was the neurologist, he wouldn't answer any of my questions, not one. I felt like a balloon that had been snipped and untethered and just flying wild. The actor David Hyde Pierce, who loved Nicky and was a friend of mine as well, told us about Caring Kind, which is an Alzheimer's primarily organization here in New York, where I went and took all the courses I could take. They offered all these free courses on dementia, Lewy body being part of it. And secondly, they were amazing in giving me a resource. And the resource was the Lewy Body Dementia Resource Center, run by a woman by the name of Norma Loeb. And for anybody who might need that resource, it's lbdny.org. They have a 365-day-a-year helpline, and and it's manned by people who have been on this journey, caregivers who have been through it. And they also have a website, which is amazing. So if you go to the lbdny.org, you get to the website and then all the things that are available to you, including many, many support groups. And so they became my lifeline, no question about it. We started on our Lewy body journey. I let Nicky do what he could do and needed to do as long as it was safe. I also asked his permission to tell friends and close relatives about what was going on, because it's very important that you get supported and helped and that people understand what this disease is and what it does. So that worked incredibly well. We got through the first year pretty well. The day came when I had to say to Nicky, it's time that we do everything together, because he fell on the way home from the post office one day, black eye, bleeding. He couldn't figure out where he'd been. He couldn't answer any of my questions. And I knew it was time to get a regime together to help him on a daily basis, which because of my business, I could do. We weathered it pretty darn well for a very long time, and then COVID happened. And when COVID happened, Nicky started to decline. There was a day when he just snapped at me one day, and it became very apparent that the anger was just outsized. And I just left the room very quietly. He came over, and the last drawing that he ever made was a cartoon of the two of us. Him looking at me, masked in COVID masks, and saying, I'm so sorry. I know you were only trying to help me. The other thing he did during this period, and we're talking about 2020, and we're talking about the months of March, April, and May. The other thing he did was to write a poem about what it felt like being trapped in a Lewy body. And I'd like to just read this to you, because it is the clearest description that I've ever read from the inside out. And Nicky wrote the following. The photo on the wall, if I'm not mistaken, was taken when our love was just brand new. It was not long ago when we were making the plans to love each other strong and be true. A devil in our home used deception to corrupt the loyal angel that my heart knew. An instant into this cruel and hateful reception, vengeance replaced the heart that once beat true. With blinding rage and searing pain, a ready knife filled my hand. I thrashed with intent, cutting them down, and never was the same again. While I wait for my date with the hangman and his chore, and by chance I see my reflection, that less than human sight that haunts each tortured night. That stranger in the mirror is me. I think that describes very clearly what a person with Lewy body is feeling as they fluctuate in and out. Nicky celebrated his 77th birthday on June 7th of 2020. The decline thereafter was pretty severe. There were times he didn't recognize me. The incontinence set in, everything that you can imagine with this disease and what one had to contend with, he in particular, was pretty dramatic. By the early part of July, Nicky stopped eating, and then he stopped drinking 2 days later. I called in 8 of our closest relatives and friends to say their goodbyes. They came to the bedroom where he was still in our bed. I didn't put a hospital bed in. I wanted to make it as normal as possible. Hospice, we had signed up for it. I had the end-of-life kit. I had the morphine and was beginning to use it. And hospice never started because it went too fast. But everyone came in, they said their goodbyes, and then I heard a voice. It was Nicky. He had not been verbal for days. I went in, he said, please wheel me into the living room. I wheeled him into the living room in the transport chair, whereupon, in a very lucid moment with a full voice, he said thank you and goodbye to each and every person in that room by name. Told me he was tired, went back. Several days later, it was Bastille Day, July the 14th of 2020. And Nicky was a Francophile, loved everything French. And he waited till Bastille Day. I was sitting in the morning holding his hand. My phone on the table behind me pinged. I looked over, just a glance. And by the time I looked back, Nicky was gone, peacefully gone. It was 16 months from diagnosis to death. That's very, very fast with Lewy body dementia. And so, Dr. Barrett has told you all about dementia and what it does and what it is and how it manifests itself. I would just like to add that there is not an easy road in dealing with it, and there is also not one path. It has many, many, many faces, which is why it's so hard to diagnose and also why it's hard to deal with. Caregiving, and this is for the caregivers out there, caregiving is on-the-job training. Nobody can teach you to do this. It's morning to night on-the-job training. In addition, caregivers really need to take care of themselves, physically, mentally, emotionally. It's vital because if anything happens to you, what happens to your loved one? It's important to let your loved one know that they are loved, protected, and safe. Again, loved, protected, and safe. Your loved one is not always able with Lewy body to express what they're feeling, but I believe very strongly that they feel every single bit of what's going on. So that gentle touch, that kiss on the cheek, the simple I love you, it gets through. I believe that. I can't prove it scientifically, but I am sure of it. Also, keeping one's dignity. If you allow something to happen, as long as it's safe, and give the person the ability to feel in charge whenever they can, it's incredibly important. And maintaining that dignity through those acts is an act of great love and great kindness. Again, incredibly important. Keeping a monthly log for the doctors. You generally have many doctors involved in this disease, and it's very important that they all know what's going on. You think you'll remember as the caregiver, you won't. I guarantee you won't. And so write it down. And also the kindness of writing it and presenting it in writing saves, again, the dignity of talking about some of this very nasty stuff in front of your loved one. And chances are your loved one will say, that never happened, when it did. So again, you avoid confrontation. Caregiving is hard. There's no question about it. And there isn't one of us out there who's not going to lose it from time to time. You simply are, because that's the nature of us human beings. And so what I recommend is that you as a caregiver keep a pillow in another room. And when the going gets rough, and it will, you go into that room and you scream at the top of your lungs into that pillow. Now, I'm here to tell you that heck, darn, and damn don't make it. They don't do it. The only thing that works is the F word, a word that I particularly despise, but nonetheless, it works. You scream the F word into the pillow. You then take a lavender sachet or a lavender bar of soap. You inhale it like a big yoga breath and exhale, and you're ready to go back into the lion's den and face the next round, having not hurt anybody, and your neighbors aren't hearing you either. So it's a remedy that people laugh at, but when they try it, it works. Support groups also, as Dr. Barrett mentioned, are incredibly important. You can't do this alone. I'm not a joiner, particularly. I was so grateful to have my support group, many of whom are still my friends, because they understand it better than anybody else can. Again, and most importantly for caregivers, you are not alone. We're here to be helpful, and we're here to support. Thank you for listening.
And I think we've had two wonderful presentations, and we're at the hour limit. So unless I hear any objection, well, thank you both for wonderful presentations.
Thank you.
Thank you all for attending. NACRA hopes to hold similar conferences in the future. We welcome your feedback and suggestions for future events. Please feel free to share your ideas by posting on our online forums or by sending an email to president@nacra.com. I say thank you to everybody. This has been fabulous, and goodbye.
Bye.